Hi, I'm Dr. Aditi Joshi, and welcome back to the Ardexia interview series. We're talking with people who are doing something almost impossible in healthcare systems, improving innovation, and talking through what are some of the problems that clinicians and doctors see in using digital tools. Today, I'm very excited to have Dr. Paulius Mui here today, who is a family medicine doctor. He is the founder of XPC, which is X Primary Care, a community of physicians who are reimagining what healthcare delivery can look like. And he also recently launched a virtual direct primary care practice that runs on a pay what you can model. What that means essentially, and as you can of course tell me if it's something different, but there's unlimited access to care via text, phone, or video. And so patients can pay what they can afford, which I really think, I love that you do that because that speaks a lot to equity. I know Pius for a long time. We met at a conference, and I'm also part of his Slack channel. And so I always love reading what you write and the community you brought together. So thanks, Pius, for joining me today.
Yeah, nice to be here. Thanks for having me. I'm excited to chat.
Great. So we're just going to get into it. So, we have a lot of conversations. There's a lot of people that we both know that, they've trained in medicine, they practice, but then they also do a lot of innovative care, or they have gotten into digital health, or they do other things. Some of it are for different reasons. So I just want to hear from you. What is it that you decided, after training in family medicine, what made you say, okay, I want to do something different and kind of break what the traditional primary care model is?
Yeah, well, so I fell into it, I would say. I did all the traditional things of being on leadership positions and on committees, and things were just super slow moving, right? I understand that these larger entities, organized medicine, exist to pump the brakes to prevent bad things from happening, but that also has like a double-edged sword where very little actually gets done. And I'm still at a stage where, like I'm a restless misfit, so to speak, and want to be doing things, want to be building things. And who does tend to have a seat at the table and more of an open arms mindset are the people in technology because, well, one is that they're pretty well resourced. Two, the right ones tend to be humble and are actually welcoming a perspective that isn't theirs. And three, I think they're just way more optimistic. And what I've learned is that it's much easier to influence optimists than pessimists. And it's just where, I got pulled into. And traditionally, clinicians just have been on the table and not at the table. And being in a place where what you do actually impacts how either technology gets built or care delivery can be changed, I think is a new standard that we are seeing with people who don't take the traditional path. And I think that's pretty encouraging. And so, like after residency, I took a gig that was building out an innovation department for a practice that had around 50 locations. And that was not something I've trained for. And just, it's one of those things where, you have a frame of thinking about problem solving and then you just work through it. And I've enjoyed my path so far.
I actually really love what you said about on the table, not at the table, because that goes into a lot of why people are frustrated. When we talk about digital tools and building this out, that they're kind of prescribed to doctors, but they're not really necessarily with the input of doctors. So yeah, I really appreciate you saying that. And thanks for giving that background. So, I'm an emergency doctor, not a primary care. And I've read, a number of studies about just how, telemedicine, for example, definitely cuts down time visits for every single specialty except primary care. But I know you talk a lot about how being a full-time primary care doctor in today's system is nearly impossible. And so can you just give a brief background to our audience who may not realize this or not understand why? Why is that? And what are you seeing as the specific barriers that make it really difficult in today's healthcare system?
Well, I think our work is largely invisible. And what people think primary care does is that tip of the iceberg. It's what they see. And it's one of those things that we often get noticed when something doesn't work. And when like the machine is humming of care delivery, that's because a lot of things get done in the background, whether it's care coordination or helping people get to the right specialists on time. A lot of the in between visit care that gets accomplished that often falls out of the traditional billable visit. And that's why we've seen emergence of these different care delivery models, because that's truly like one innovation that has somewhat gathered a groundswell over the decades, because that allows people to not have to transact in these encounter-based episodes. And care, like being sick is a continuous experience. You don't get sick from 9 to 5 and then you pick it up the next morning, right? And so relating and matching where the patients are at, I think, is really what we do. And then I think that also technology is finally allowing us to be reached in new ways. And so that adds another layer of burden. And I mean, there's lots of reasons why things are messed up. But also, I tend to try to focus on all the different solutions of how you can go around it and hack it and actually work for patients.
I get that too. And I appreciate that because I do think part of it is invisible, right? Because technically you guys are the connection between everybody's healthcare, but it's not always recognized as such, which is a lot of work. And when you're talking about people now can access their physicians, right? A lot of people use My Chart in their EMR, or they're able to text. And a lot of patients don't realize that it does take time that often is not reimbursed. But, going to your actual virtual first practice. So, you've built that out, and I really like that idea that you're going to be really accessible to patients. Like, how did you decide to do that? And how have you found it? Because people are going to ask, how is it financially feasible? Like, how are you making this work?
So the reason for me to create this unrealistic, unsustainable model is because I did not want to give up medicine. So it is not really repeatable at scale. It is not for everyone. It is just my way to create an environment where I get to be fulfilled in practicing the kind of medicine that I've always imagined, with as little interruption between like the patient and myself. And the best way to kind of create that is just by finding a mechanism that makes care accessible. So that's why patients get to pay what they can afford. I think that really overcomes the financial barrier. And then I chose to take the virtual approach because it matches my lifestyle, because I'm often 90% of my time is spent building a technology company, and that involves travel and being in meetings and so on. And so, as our friend Matt Sakamoto has taught me, that time can make up for touch. And so while virtual care certainly has limitations, in primary care you can do a lot. You can take patients really far, because if they have an active symptom ongoing, traditionally we usually have to decide what to do in a 15-minute time frame, and then that's it, right? Like, it's very unlikely that people even will be able to come in the next day. But with virtual care and a payment model that doesn't think about episodic care, we can text every few hours throughout the day or into the next day and actually figure out, is something going to resolve on their own? Can you symptomatically manage it? Or do you need to escalate it? And then where do you need to escalate it? Because sometimes patients go to the wrong point of care, right? When something should never be handled in urgent care, ER is sometimes more appropriate, or vice versa. And so I think it's a true value add for everyone involved. And by doing this type of practice, I just find that patients are really receptive. Like, I have been getting contacted from people who see my card at a grocery store because I pinned it up to like a community board. I was invited to just canvas at a farmer's market and let the community know that this is happening. So it's just been a really cool way to plug in with people who are just part of life. And then there's also this element of, I did not want to give up medicine because I think it really humbles you. It reminds you how difficult things are and like how difficult care is for patients. And that's just a really good reminder to be close to the problem. And I like to problem solve in healthcare. And so when I had to go do the licensing in Massachusetts, there are all these unwritten rules that something had to be mailed with a stamp and a check, and there's no way to pay via the internet. And then a form needed a wet signature, but then I had to fax that form to another entity. It has been a great learning experience. And I think I have a lot of appreciation for people who've actually gone through this and pulled it off themselves.
I agree with Matt completely. I have also found that just being able to have no interruptions and speak to the patients really does make up the fact that they're not in the same room as me. Obviously, emergency medicine isn't a field that is built for continuous care, but the way that you set up your model reminds me kind of like the old models of way doctors worked, right? There would be the one doctor in the area, and that's who you would call, and then they would know their community, they would know everybody in that community, right? So you get to know your patients really well that way and get to plug in for your.
I'm still building up my practice. I have a license in Texas where I used to live, and now I live in Boston. So I have a practice, and I think I'll keep the two of them because I have patients already in both states. And realistically, I can probably manage a panel of maybe 100, 150. That will probably amount to like 10% of my time. It's like you can't be everything to everybody, but this is, I think, my way to help out people who might benefit from good care, if that makes
Yeah,
sense.
I love it. And it really talks about the equity that both of us have had many conversations about.
Yeah.
But taking a little bit of a different approach, you work in, the X primary care, you run hackathons, you do a lot of innovation, you build a lot of products yourself. I've met a lot of people who work with you and have learned how to innovate. Can you give us some lessons that you've learned and what you've actually come across in the way that what do doctors need to actually innovate? And what do you find either is a benefit of clinician innovators or what tends to get in the way, like both of those things?
I think innovation is such a funny word. I think often it is something that others label. It's not a label I seek out, but it's what happens. It's what, the industry calls this work. And to me, it's just doing something new and not necessarily like asking for the permission to be different. I think that you have to have a framework in which, test technologies or procure different vendors, and how, being able to, I think, translate between different domains and different layers is kind of what makes innovation happen. So for me, it was becoming more technical. And so the translation layer between clinical and technical, I think, is the most interesting space in healthcare. And I just admire engineers because they're magicians. They can make something from nothing, and that is a skill set that I'm building up myself, just out of pure curiosity. And so, someone who's in innovation is someone who is committing to being curious, I think. It is my perspective. I think it's one of those where you can ask different innovation people, 10 of them, and you'll get kind of 10 different opinions. But that's how I see it. I think that often medical training self-selects for people who are used to having one correct answer. And as we know, like patient care, things are in between the lines. They're gray zone, blurred. Nothing is clear. And you just kind of have to really be comfortable with that discomfort. And then oftentimes, and now I'm building a company, and I'm taking the path less traveled of not taking external funding, which is good and bad because it also allows me to focus on things that I think aren't directly most profitable at the beginning. And that's what dissuades a lot of people that try to, get on a rocket ship and grow fast, which can be exciting. But I also think it gives people an opportunity to find a really hard problem, work towards it, and then maybe down the road benefit from that compounded effort. If that, that is just, I think, an approach with primary care as well. It's if you do things that are, good for your health and so on, and like these incremental improvements really stack up over a lifetime. And I think that translates similarly to doing the right thing in primary care, innovation, entrepreneurship. So to me, this is all very similar.
I was just thinking when you were saying that, because, we talk about in medicine that in some part we pick our specialties, but our specialties also choose us because, in emergency medicine, we tend to really want things to be fast and we want to be innovating and iterating really quickly. And then when you were talking about this slow and steady to try to build out the right thing, that really does inform what primary care is, right? The preventive care into the long-term care that you see for your patients. So I found that really just funny in that way. But it also makes me realize too, when you're talking about building, I've also come to that point where I realize that sometimes building things slowly and surely is going to, be a better way to actually fix some of the bigger problems that we find. And, we've been talking about this, and what a lot that I have looked at is really that clinical adoption problem, which when I started 12 years ago, I mean, this is a problem in general, but with any digital tools, this has been something that has been over and over and over has come up as an issue. or as a barrier, because some of the other things that ended up being barriers when I first started tend not to be. And so, I wanted to just get some of your thoughts on this. That, like, when somebody like yourself, or what you have learned when you've been working in innovation and with clinician innovators, how do you actually think through this problem of, all of us are curious and optimists, but most of our colleagues, who are working or in the trenches or working in the innovations in other parts of medicine, and we're trying to give them or implement this into our practices. How do you see that, like, working, or what have you seen, at least in primary care or in anywhere that you've seen it? How do you actually think through this problem?
Well, I think it's about being part of the leadership team. So there's been some interesting discussions lately. Should physicians be or clinicians be involved in health tech startups? Nikhil from Out of Pocket has written this post, and he's asked me to send in a comment. So I'll kind of reiterate what I think will get shared out there too. But there's lots of rational arguments for lack of direct ROI or even potential drag on the velocity of how a startup can grow if clinicians are in the mix, right? Like, not everyone is trained to know how to navigate just the growing enterprise in the startup space. But what's interesting is like sometimes you really want to have people around that think beyond term sheets and whatever is on P&L, because I highly recommend everyone to read Careless People. It's the Facebook whistleblower story, and it is basically an argument of morality and what happens when, like, different business pressures and system just almost conspires for you to create products that actually harm people at scale. Because technology is an amplifier, right? And so if it's the same way that if you digitize a bad process, you get a bad digital process. And same thing, if you enable a technology that does something that doesn't actually benefit people that need care the most or vulnerable populations, you get to propagate a lot of the biases in the system and take shortcuts. And, like when these startups investors say they wind down, but what happens in reality, people's lives are destroyed, the patients get left out cold, and like care is interrupted. So it's nothing about winding down. It's like completely disruptive, and it has this like splash zone effect that someone just goes and creates a new deck for their next adventure, but like there are real repercussions when people's health is involved. So I think there's that. I also think that there's an opportunity for clinicians to actually be on offense and be involved and trying to learn different skills. One of my very first blog posts when I just started writing around 2022 was around PMF. There's this business concept called product market fit. And I framed it around physician market fit, because you get product market fit when like the market pulls the product out of the company, because like everyone wants it so much. And I really think that like physicians have that de facto. That there's so much need that you just get pulled into this ecosystem if you're ready for it. And you kind of have to understand some of the business terminology. You have to understand what are the incentives. And so it's not like someone's just going to pay you for consulting to be like on a pedestal indefinitely. But I do think that it takes effort on both sides to try to come together and build something worthwhile.
Yeah, I completely agree. And there's a lot of nuggets in what you said, like I like that physician market fit, and also about leadership, and that there's real repercussions when we have to make decisions. We make decisions on behalf of others as well, right? Yes, of course, we have discussions with patients, but it has real repercussions. And so we can't just do whatever we want. Quick last question. So you compiled a resource guide for physicians who are interested in direct primary care. For anybody out there listening and they're curious about doing something like that, what are the first couple of steps that you would tell them to take to become involved in that?
I would say meet other people who are asking similar questions. Like you don't need to have the answers to start doing something. And so reach out to me, reach out to others who are writing about primary care. I mean, they should definitely contact you and follow all your work, because I think you tend to surface ideas and create a space for interactions that just tends to be on the earlier side of adoption. So it may not be on every billboard out there, but it's what ends up shaping what people do. So I would say, just follow your work.
I really appreciate that. Thank you. Thank you so much for coming. I really like what you're doing with that type of practice, with the equity work and all of the innovation that you're doing. I appreciate all your comments. And for anybody who wants to follow you, we're going to link to the XPC as well as to your Substack. And so I'm sure I'll see you soon. And thank you so much for being here. And to our audience, if you're interested in these topics, until next time, we'll see you then.
Thanks for having me. Okay. See ya.
Thanks. Bye.